Thank you.
Okay. So to everybody who's in here, please don't disappear. We're just waiting half a minute for people to come in before we start this webinar. Okay, so it's 2 minutes past 5. I think we can start. We already have over 100 participants in this webinar. I'd like to welcome everybody of you to this webinar, to this ENS webinar. The topic of today is management of spinal metastases. And as we all know, that there has been a shift in the management of spinal metastases in recent years. As we see more spinal metastases we need to treat with the increasing efficacy of the treatments of any tumor. We see more and more spinal metastases, and the surgical treatment gets a different flavor, as we're no longer treating only salvage surgeries for neurological deficits. We're now talking about oncological consequences of surgery or oncological consequences of the other part of the therapy, of radiation therapy, apart from stabilization and neurology. And therefore, I'm very happy to have two speakers tonight from both sides, which is on the radiation oncology side, Stephanie Combs. Stephanie Combs is the chairwoman of radiation oncology at the Technical University of Munich, and she will speak on indications and limitations of stereotactic body radiation therapy in spinal metastases. And then as a second speaker, we'll have Bart de Pruitere, who's professor of neurosurgery from Leuven University in Belgium, and he will talk about surgical concepts for spinal metastases. But first we start with the radiation oncology aspects, and we'll hear about the different radiation therapies and the indications and limitations of radiation therapy in spinal mets from Stephanie Combs, please. Oh, that's what, excuse me, one more point. I forgot some housekeeping. Your questions, please type in your questions in the Q&A box for the later discussion. We'll have the questions there, and I'll give it to the speakers to discuss your questions. Thank you. So now, Stephanie.
Okay, great. Thanks, Florian, and the organizers of this webinar series for the invitation. I'm really happy to join in and share my opinions and experiences and recommendations for the management of spinal metastases from the radiation oncology perspective. And to start off, I brought a case, which is maybe not the typical spinal met case, but it was a patient with an esophageal tumor that had locally metastasized into the spine. And the patient was presented to us as a metastasized patient with the question to do a palliative treatment of the metastasis. And then we critically discussed with our visceral surgeons the indication of the case and for this patient. And we decided we'll take this patient into a curative concept, treating the esophageal tumor with really high doses to esophagus, while also treated in a curative intent. So this patient, inspired patient, was treated with chemoradiotherapy with 54 gray and 1.8 gray single doses with a integrated boost to the macroscopic tumor with concomitant chemotherapy. The patient then had a local recurrence, and this recurrence was not in the region of the esophagus, but it was in the region of the spine. And you can see here the recurrence of the tumor. And then in this case, the patient went for surgery Still, although it was a metastasized patient, we put all efforts in treating this local disease. And something you can see very nicely if you look here into the instrumentation, it really depends on the instrumentation the surgeon will put in, and probably the surgical colleague will also put a focus on that. And in this case, you can nicely see the anatomy and the tumor recurrence. If you would have an instrumentation like this, having the high rate of artifacts, it would be very difficult for us to delineate the tumor, to see any recurrences. And those post-operative images do really make a difference for the radiation oncologist. Why am I presenting this case? First of all, I'm presenting the case because I think it's important to see if we have a metastasized patient into the spine, it's not all palliatively yet. We have to put all efforts in to treat these patients, and they do have a benefit of extensive treatment, this being surgical approaches, and then of course together with radiation oncology. But I'm also showing it to tell you that the type of implants our surgical colleagues put in can have a difference on the radiation oncology treatment planning. And it does really make a difference if you see the anatomy, see the tumor, and maybe after treatment even detect recurrences earlier. So it is important to discuss cases interdisciplinary and maybe also before surgery to discuss which treatments are necessary in the end and which implants are better for the patient. Now let's get back to the patient and to the typical patient with a spinal met presenting with a variety of symptoms, with pain, with neurology deficits, and in some cases also being a very painful and urgent treatment indication. And if you go back 20, 30 years, and even during the time I was trained, treating of a spinal met was a very simple radiotherapy. We had these simple radiotherapy fields, as you can see them here, just one dorsal field from the back. We gave 10 times 3 gray and the patient was treated. And this has now really advanced to more elaborated treatments, also including high-dose treatments such as stereotactic body radiotherapy. But now let's get back to the signs and symptoms that are important for the radiation oncologist. Of course, it is the clinical examination. It's maybe x-rays that have been done, but more and more, of course, CT and MRI, but also sometimes PET imaging if you want to look at the vital tumor areas. Then it's important to see which symptoms does the patient have and also how quickly that those symptoms develop. Because if a patient really develops symptoms very quickly, this can be an urgent indication in most cases for surgery. But if for some cases surgery is not possible, also radiation oncology can be an urgent treatment that should be performed within 6 hours of the beginning of these symptoms. So it's important that the clinical examination and the patient history should be done thoroughly. Time course, as I said, of the symptoms are very important. And as already pointed out, even if it's a metastasized patient, I think we have a local problem in those cases, and it is really our task to treat this local problem with the most advanced techniques we have. Even if we do say we have a patient that is thoroughly metastasized, sometimes high precision radiotherapy, sparing normal tissue, having very low side effects can be indicated in such a case. And it doesn't mean if you have an advanced treatment, you don't need advanced technology. It doesn't mean you need to do quick and simple treatments. In some cases, you even more have an argument to use these advanced technologies that are really associated with very low side effects. Radiation treatment of spinal lesions can be several reasons. Of course, we have the primary tumors, secondary tumors, and then we're mainly focusing on secondary tumors. We have the curative versus palliative intent. We're personally, since we want to generate local control, this curative versus palliative probably in spinal radiation oncology doesn't make that much of a difference. Then, of course, it's patient performance status, of course, that you have to look into. It is the questions, do we have multiple lesions? Do we have a single lesion disease? Are we in the so-called oligometastatic setting, where it is really a benefit for the patient to use local high-dose treatment? And then, of course, it's the location of the tumor we have to look into, because for some indications, we do have a risk of fracture. In some indications, we have to consolidate after surgery. And in some cases, even it may be appropriate to do radiation as a neoadjuvant treatment, which maybe is very individual, but in some cases, patients benefit from those approaches. So now let's look back into the older data, not focusing on stereotactic body radiotherapy, but focusing on the classical 3D radiotherapy. And I know in some departments or in some clinics, there is always this decision making process. We need a quick radiation treatment. In some countries, this one-stop shop radiotherapy is promoted, meaning the patient comes, has their treatment planning on the same day, gets their single shot radiotherapy with, for example, 1x8 gray, and then the patient is treated and goes back home. This may be true for some patients, but I think from my point of view, we should still apply that with caution, because there are some older data out there that we shouldn't forget. This is a study published in 2011 comparing short dose radiotherapy with long course radiotherapy. So this 1x8 or 5x4 versus 10x3 or 20x2. And if you look at neurological improvement or neurological deterioration or motor function overall, you will see there is no difference between these fractionation concepts. But if you go one step further and you look at local control, and this graph shows local control at 1 year, you see clearly that long course radiotherapy leads to a significantly longer local control. And I always tell my residents 10x3 gray, the patient will be back in a year. With 1x8 or 5x4 gray, the patient will be back within 3 months. And we have seen a lot of those patients because systemic treatments gets more effective. We have immunotherapy, so patients live longer and they do come back. And then it's difficult to treat them. So my credo is, if you treat a spinal med, don't go into those palliative concepts, really give the patient a good treatment. And if it's a couple of days longer, the patient will benefit if you do conventional radiotherapy and you can't do stereotactic radiotherapy. Then here are also some older data looking at the spinal cord compression patients, asking the question, do we do radiotherapy alone, or is the decompression surgery really a benefit? And I know in some centers there is a discussion saying, well, if we have a spinal cord compression and the patient is in bad performance score, just bring them to palliative radiotherapy. But I think it's worth looking at the patient because you can really see that the combined treatment with surgical decompression followed by radiotherapy has a benefit on motor function. And I think the interdisciplinary evaluation of these patients is really essential, and they just shouldn't be brought quickly to like a palliative radiotherapy because the patients don't benefit from this single treatment. So now let's go into the basis of radiation, because we want to look at the techniques and doses. And just a quick reminder for all of the non-radiation oncologists in this webinar, radiation works like a medication. Yeah? The more dose you can give to the tumor, the higher is your local tumor control. And you can see that here at the blue dose response curve. And we have this very similar dose response curve for the development of adverse effects. And of course, if you look at the spine, the spinal cord is our main organ at risk. You all know this is something that will not be repaired and has mental effects for neurology. And then also there is a large variety of techniques available, and I think it's really important that if patient with a spinal med is treated in a center, they shouldn't just have one technology available, because if you just have one technology, you can just treat with this one technology, and not every patient is the same, and you might have to choose other devices depending on the location, on the indication, and so I think this is really important for the quality of treatment. And one technique I want to point out is something that is maybe not often discussed in the context of spinal treatments, but it's the tomotherapy system, the helical IMRT system. Why is it nice to treat those patients with this machine? Not because the dose distribution is a lot better, but this machine has a megavoltage imaging compared to the normal kilovoltage imaging. And the images you can generate are more artifact-free than our conventional cone beam CTs as all other machines. And especially if you have a patient with instrumentation, it really helps to reduce the artifacts and to secure patient positioning. So especially for those spinal lesions, often primary tumors that have instrumentation, it is really beneficial, for example, to use the tomotherapy machine. But depending on the indication, depending on is it a stereotactic treatment, also other equipments and machines are possible. One novel, or maybe it's not that novel, it has been really established also in clinical routine, at least in the specialized centers, is stereotactic radiotherapy for lesions in the body, for small volumes, lymph nodes, but also spinal lesions where you can really deliver the dose to very small and targeted volumes. And just for you to see how this high-dose stereotactic treatments work, I brought one case. I know it's not a spinal med, but I like this case because it's nice to see what happens if you do stereotactic treatment. This is a 79-year-old patient, initial diagnosis of prostate cancer, and the patient had an increase of PSA and came to our clinic with the question, what do we do? And what we did at that time was a PSMA PET CT. And in this PET CT, we saw one bony lesion. In this case, the lesion is not in the spine, it's in the pelvis, but it could have been in the spine. It could have been a spinal med. And the patient, even if it were a spinal med, could have been treated with stereotactic body radiotherapy with a very small high-dose treatment volume. And what you can monitor nicely in prostate cancer is the effect of radiotherapy. And in that case, the PSA decreased below 0.01, so below the detection level, basically, without androgen suppression therapy, which would have been the treatment standard in that patient, which really can be associated with detriment in quality of life. So just to see how this local ablative treatment works as a surrogate with this PSA value. If you look at the spine, there are several concepts to use the stereotactic body radiotherapy as radiotherapy only. Now, you can use it in 1 fraction, 24 gray in 1 fraction, 27 gray in 3 fraction. And so it depends on the institution and their experience. It depends on the volume of the lesion and also of the treating physician's experience, which concept you would want to apply. And there are data out there that show you that these high local treatments lead to a quicker and deeper pain response than conventional radiotherapy. You can also apply SBRT postoperative. This is a little more complicated because you really have to look at the resection bed. You only mainly have retrospective studies. And as you all know, depending on how surgery was done, you might have a larger volume, which might be associated with higher rates of side effects. So in my view, this postoperative SBRT is a little more tricky. But there are strategies to mitigate those toxicities, really sparing the spinal cord. You can see it right here, how you can take out a donut in the middle of the spinal cord. And the length of the spinal cord that is treated, and the longer the treatment field, the higher the risk for side effects. So that also might be a limitation, that in those longer treatment volumes, you might not want to do SBRT. SBRT might be the best of the patients. This study again showed us local control in patients treated with SBRT, and what they showed nicely, that local control is higher in patients that have less spinal cord compression. And if you look here on the left, this is not local control, it's local failure. And the blue curve, those are the ones with really a high grade spinal cord compression, had the highest risk of local failure. This, in my view, is mainly due to the fact that those patients have a long extension of compression in the spinal cord. And you do have to reduce the dose to the spinal cord not to risk toxicity. And of course, that in turn leads to this higher local recurrence rate. Something that I consider very important is the figure 3 on the right, and that looks at vertebral compression fractures. You might have noticed in different communities and settings, SBRT for spinal mets is really propagated. Yeah, and you might have noticed in my talk that I say it's an option, but maybe not for every patient. And one argument I have, in spite of the length of the tumor and maybe the postoperative difficulty, is that we do have up to 30% of patients developing new vertebral compression fractures after SBRT. And this is something you really have to keep in mind, that can be a side effect after SBRT. And I think, of course, you can do it. And of course, it may be safe in the majority of patients, but still you have to keep it in mind if you apply SBRT widely. Now, let me get back to the question of the spinal implants. And there is one trial that we did, and there's something going on. There's one trial that we did comparing carbon implants with sort of classical implants after radiotherapy, after surgery. So what we did, we took 10 patients that had titanium or carbon implants, and we did different treatment planning approaches, protons and also IMRT approaches. And you can see in the first place the difference in artifacts and anatomy that we as radiation oncologists see after those implants. And then if you look at the treatment plan, comparing here above, you have the titanium implants. Down here, you have the implants. And let's go to the one on the left. This is the proton plan, but just look at, for the non-radiation oncologist, at these peaks here. These are dose peaks within the abdomen that you don't really need, just being artifacts from the implants. And if you look at the carbon down here, these peaks are significantly reduced. And this is the same for VMET and IMRT plans here on the right, although the differences are not as pronounced as with the proton treatments. And if you look at the details, don't worry, I'm not going to go through all data in detail, but you can see nicely that the homogeneity of the plan, the dose to normal tissue, and also if you look into the artifacts, all of that is reduced using the carbon implants. So a benefit in the first place for the physicist and the radiation oncologist to produce robust treatment plans, but in a second step, of course, for the patient, because we can deliver treatment more securely and we can spare normal tissue. And this is one patient we did treat with SBRT after carbon implant. It was a patient with breast cancer. She had a solitary lesion. And you can see on this image how nicely we could identify the target volume for treatment, how minimal the artifacts were, and then how easy in a second step for us it is to define the target volume, and then in the end to to calculate the treatment plan and to deliver a safe treatment to this patient. So, a general statement, precision therapy has been, and I hope this has been clear from my talk, but I think the techniques have really evolved, and I think for patients also in a metastasized setting, we shouldn't say, well, they're metastasized, that's palliative. I think we should say we have a local problem and we have to solve it, and we have to solve it long-term because patients have long-term survival, because systemic treatments are better, patients do live longer, and we have to apply modern treatments to reduce side effects, to really increase quality of life. And I think to deliver that, the patient-centered interaction at the centers is important, and it's also important to have a good interaction between surgeons and radiation oncologists before surgery, after surgery, because then you can decide hand in hand what is best for each and individual patient. Thank you very much.
Thank you very much, Stephanie, for this nice presentation showing us the options of radiation oncology in the treatment of spinal metastasis. Before we get into the discussion, I would like to have the second presentation on the surgical options. And Bart de Praat is now here. I already introduced him in the beginning, and he will give us now his view on the treatment of spinal metastasis and about the surgical concepts we have for those patients. Bart.
Thank you, Florian. You should be able to see my screen now.
Yes, we can see your screen.
Okay, so my talk will be particularly on surgery, but in the end, I will emphasize the multidisciplinary nature of treating patients with spinal metastasis, and therefore I'm glad that Dr. Coombs already enlightened that as well. Spinal metastases, the first description when we go back in history was in 1925, in the previous century, where the first report appeared of a patient with a paraplegia due to a metastasized carcinoma, as you see here. And from there on, actually, patients with spinal metastases were considered as, well, a very fatalistic approach was taken over the decades following that, because not a lot people could do about it, and the Karnofsky indices, the performance of these patients dropped, and they were actually considered in a very palliative state. And patients were sometimes treated with radiation therapy or were treated with surgery, and in those days, surgery consisted of laminectomy. And in the late 70s and 80s, the first randomized trials appeared comparing radiation therapy and laminectomy. So the surgery then was laminectomy, meaning that if you know that most of the metastases in most of the spine, but most appear in the thoracic spine, actually come from within the body and push anteriorly on the spinal cord. So when you do laminectomy, the spinal cord will be kinking and pushed posteriorly, and that will or may result in even worse neurology. And so, not surprisingly, the results of those randomized trials in those days were negative for surgery, and radiation therapy was doing better, but not that great. The overall response in the systematic reviews of those days and those treatments of conventional radiotherapy were about 60%, so not that great. Obviously, in the 90s, surgery improved. There were a lot of technological advances, cages being introduced. The early 90s, the pedicle screws were popularized, etc., etc. And also the surgical approaches were developed further and further. Surgeons could come from anteriorly, laterally, posteriorly, etc. And so that prompted people to do a new randomized trial. We all know the Patchell trial, published in 2005 in the Lancet, where he compared patients that got surgery plus radiotherapy and patients that got radiotherapy alone for metastases causing spinal cord compression, either with neurology or without neurology, just based on radiology. And the monitoring committee at that time, halfway the study, prompted the researchers to stop at the study because it was considered not ethical to go on, as the results were so significantly in favor of surgery preceding radiotherapy. And you see here, and most of you will know that study, maintenance of continence, maintenance of Frankel and ASIA scores were much, much better if the patients were treated with surgery first preceding radiotherapy, and indirectly also there was a better survival in those patients. So from then on, the best treatment for spinal cord compression caused by a solid metastatic cancer, and I will come back to that issue, is surgery as initial treatment, followed by radiotherapy. And that has been confirmed in other studies as well. This is in a publication from the Global Spinal Tumor Study Group, and I believe that this is still the largest database to date, with up to 2,000 patients that were treated surgically for a spinal metastases. And what they prove was that the outcome after the surgery, the quality of life after the surgery, was very much dependent on the quality of life and the performance status before the surgery. And you can see here, if the patient had a Karnofsky index of 60 or more, the orange and the red curve, then surgery followed by radiation therapy was able to improve quality of life and maintain that over time, over almost 2 years, as you see here. So still talking about spinal cord compression, the instability we will talk about later. Talking about spinal cord compression, what surgery can be done? Also the Global Spine Tumor Study Group made a categorization into 5 categories of that. So the first is the just palliative laminectomy, as was done in the old days. The most frequently performed surgery is number 2, is the tumor debulking, and then usually with reconstruction, obviously. And then 3, 4, and 5 are total vertebrectomies, where the surgeon aims to completely remove the tumor, either piecemeal, which is 3, which means intralesional. 4 is an intended en-bloc surgery, but with a failure, there was a breach, and so the surgeon went intralesionally. And then 5 is the successful en-bloc surgery. And people developed algorithms to help decision making on what surgery to perform. You see here an older algorithm by Stefano Boriani and his team. So where they found, for instance, that if a tumor is not really sensitive to systemic or radiotherapy, and if it's not an isolated metastasis, they would go for debulking. But if it would be an isolated metastasis, they would go for an en-bloc surgery. There's other examples of that. One of the most famous examples is that of Tomita, based on his own database and the Tomita score he developed in that database. He performed different kinds of surgery. You see here that tumors were categorized based on their aggressiveness, and that's a little bit of arbitrary categorization that has been debated, or questions have been asked about that. But 1 was slow growth, 2 was moderate growth, and 4 was rapid growth. Then whether or not the patient had visceral metastases that were treatable or untreatable, and then the presence or absence of bone metastases. So patients got a score between 2 and 10. And then if the score was higher, patients were considered in a higher metastatic load, a poorer condition, with an expected shorter survival. So they would only do supportive care or palliative surgery in those patients. And you see they would go for more aggressive surgeries. In 2 and 3, for instance, they would do a marginal or a wide en-bloc excision. You see the survival curves on the right side, and you see that for the more aggressive surgeries, the survival is better. But obviously, these were different types of patients, as explained in the scheme on the left-hand side. Also, the Global Spine Tumor Study Group looked at that, and when the en-bloc surgeries were corrected for all the other patient and tumor factors that were involved, there was only a marginal effect of doing an en-bloc surgery on survival. So still, when we want to decide on what surgery to do, the first question is, can we actually cure a patient with an isolated spinal metastasis? If we would like to do that, we would consider an en-bloc surgery, and the en-bloc techniques have been published and taught to many people. Many people are able to do it. Well, here you see some reports. Most of them originally were from Japan, where people did en-bloc surgeries, typically for thyroid, breast, and renal cancer in isolated metastases. And you see here that in those patients, but usually only after a couple of years, we do see recurrences of the tumor. In the first study, for instance, 2 out of 8, but only after 4 and 8 years. 1/3 in the second study after 2 years, 1 out of 4 after 2 years, etc., etc. So the patient is not free of the risk of recurrence if you do an en bloc surgery in a metastasis. Also, Tomita published on that, and you see on the top of the graph, you see his wide or marginal en bloc excisions. And also there you see that the patients with an arrow are those who were still alive. So there were many people still that had died meanwhile from metastases other places, obviously. And the gray line indicates those patients that had a recurrence of their original spinal tumor. So even after an en bloc, recurrences were seen, meaning that we cannot cure patients by doing en bloc surgery if the problem is a metastasis. Second question, so when we switch to debulking surgery, can spinal cord compression recur then? Obviously, the tumor is not gone, tumor is still there, but is the patient at risk for recurrent spinal cord compression? And obviously the patient is. There are several reports in the literature, and I have summarized most of the findings below here. If we speak about loss of local control radiologically, that's about 1/3 of the patients that will run into that risk. If we speak about recurrent symptoms of spinal cord compressions, that will be about 1/5. And then between 1% and 8% of the patients in series that are published will have repeat surgery. Obviously, that's lower because all those factors will be taken into account when a decision is made, and sometimes the patient will not wish a surgery anymore, or the oncologists will plead against it, etc., etc. We looked at the predictive factors of that in the database of the Global Spine Tumor Study Group, and also looked at repeat surgery. So we had 3% of repeat surgeries in the database, which is not a lot. And when we looked at all the initial, so before the first surgery, initial patient and tumor factors, we found that we could not accurately predict that a patient would be in for repeat surgery. That would be helpful, obviously, if we could do that, because if you would know those factors before this first surgery, if you would know that this patient has a high risk of recurrent spinal cord compression, you would probably be more aggressive in your surgery. So, but the conclusion was we cannot predict it. And the only factors we find that were associated with repeat surgery, as can be expected actually, is patients with longer survival or longer expected survival due to less aggressive tumor biology. So yes, it can recur and it happens. How often does it recur, and when does it recur? So we looked into the debulking instrumented surgeries, again in the same database. I think we had a little bit more than 900 patients in there, and we found that so for debulking surgery, with or without, with instrumentation, I mean, as had been published by the GSTSG, we were able to improve the quality of life and maintain that over 2 years. We were able to reduce pain and maintain that. Also, the Karnofsky improved, and it stayed on that improved level. Now, looking at the Frankel score, if you compare the 3 months post-op with the pre-op, you see an improvement. So there are less dark gray patients. So the patient A and B, so the lower Frankel scores, so were less because of the surgeries. Patients improved, and also because meanwhile patients died. And you see that pattern also taking place up to 6 months. And then at 1 year, you see dark gray patients appearing again with an A or a B, meaning that some patients had recurrent spinal cord symptoms at that time. The exact number in this series was 18%. Now, in the same series, the survival in those patients at 12 months was about 60%. So 40% had died, meaning that if 60% was still alive, and of those patients alive, 18% had a recurrence, it means that if you speak with the patient on beforehand, before his initial surgery, you can actually say that in this context, about the risk is about 12% of having a recurrent spinal cord compression at 1 year. And that's what you have to take into account, discussing with the patient, but obviously also with the oncologist and the radiation oncologist, when you try to estimate the survival of that particular patient and the chances and the lines of treatment he still has available to him or her. These numbers are important. And if you expect the patient to have a very long survival, so maybe it may be justifiable to do more aggressive surgery. So it all comes down to estimating survival, and as difficult as it is, different scores have been developed and have been published. We did a systematic review looking at performances of the different scores and systems in those studies that compared different scores in different cohorts than the development cohort, because that's important, and there are performance indices that have been statistically developed to look into that, like discrimination and calibration scores, etc. And what we found was that the individual risk prediction scores, where you enter all the patient individual factors into a calculator, and that gives you then an individual patient risk score. And examples of that are the SORC nomogram and the SORC machine learning algorithm. Those actually largely outperform the traditional risk score tables like Tomita and Tokuhashi, the modified Tokuhashi, and the other ones we know. It's a very user-friendly thing that is available on the internet is the SORC algorithm. So you can find it at this URL as I show here. So if you Google the SORC algorithm, you will actually find it and you can use it. You have to know that it does help. Obviously, it does not tell the whole story. Each patient is different. They're not perfect, these scores, and it is definitely adamant to speak with your oncology or with the patient's oncologist and radiation oncologist and take different factors into account. For instance, what we found in a small study we did in our series is that the progression or the interval to progression on the last line of treatment was actually a very strong predictor. And this is not available in any of the previous scores I talked about. And the oncologist and radiation oncologist will be able to tell you about this. One more thing about spinal cord compression and dealing with it. Some tumors are very vascular. And if you attempt for a debulking in those tumors, you might get serious bleeding problems, and the patient may actually die on table in the worst case. And examples of those are the renal cell carcinoma, the thyroid carcinoma, the hepatocellular carcinoma. And so in those tumors, when you know that it's a tumor like that, it's actually wise to consider or to do an embolization on beforehand. So that was about spinal cord compression. The other issue to discuss is instability. Fractures can cause, or metastases can cause pathological fractures or imminent fractures. And therefore, a good thing that has been developed was the SINS score, specifically to assess that based on location, on pain, on the bone lesion being lytic, on the spinal alignment, the degree of vertebral body collapse, and the involvement of posterior elements. It's been validated, it's been considered a very good score that is widely used, and based on the sum score, you can actually, well, that helps in your decision. If the sum score is between 0 and 6, you can consider it as stable. If it's higher than 13 or 13, it's considered unstable, and in between, it's potentially unstable. And that score, as I say, is widely adopted and has led to some shift in emphasis. Whereas after the Patchell study was published, people would go for debulking in spinal cord compression with or without stabilization or reconstruction, and then add radiotherapy if the patient had not been irradiated before. Nowadays, and also I see also oncologists actually applying it, and their trainees applying it, and the radiation oncologist as well. They apply the SINS score, and when the lesion is considered unstable, they ask for a percutaneous stabilization, or at least that's what we do, to then add radiotherapy. And the debulking is then only considered when spinal cord compression comes and arrives. So many patients, when they present with spinal cord or imminent spinal cord compression, obviously you would do the same as initially, but we pick up patients earlier now because everybody's a bit more focused on it. You hear me talking about radiation therapy, and that's a definite yes. And also Dr. Combs has emphasized that. If you do debulking surgery, that's obviously intralesional surgery, and that will usually be the surgery you will be doing. if you do en bloc surgery, a more aggressive surgery, as I said and pointed out, the patient still is at risk for recurrences. So in metastasis, you definitely need to add radiation therapy and present the patient to the radiation oncologist, even if he or she already has been irradiated, because there are still sometimes options to do additional radiotherapy. And I will not go into the radiotherapy because you had an excellent presentation on that. Things are changing. For instance, stereotactic radiosurgery has been introduced, being more focused. And that has led to some concept changes or attempts to change the concepts in surgery. And a very fancy one is the separation surgery concept, where those authors say, well, the only thing a surgeon actually has to do is to create a corridor around the thecal sac and the spinal cord to make the radiation therapy safe, and the radiation therapy will do all the rest. And the only other thing you have to consider is the sin score and the stability. And I'm not saying that is not really untrue, but if you do debulking surgery and while you are in, why would you leave additional tumor and only create a corridor? I mean, all tumor you can take, it's probably better to take it while you're there. And the thing about being minimally invasive, because that's also promoted in there, is not actually about the amount of tumor the surgeon takes. It's about the soft tissue damage, because that is important for tissue healing, for wound healing, and for potential wound complications following the radiotherapy. And that's the important thing. So it's not about how much tumor you take. When you're in there, take what you can take safely within that treatment you have chosen. And if you choose for a debulking strategy, well, take the maximum you can in that debulking paradigm, but be sure that you do not injure the muscles and the soft tissues more than is needed. For instance, you will use, it's advocated to use percutaneous screws and to use minimally invasive concepts wherever possible to minimize wound complication risks. And there are several studies, and you will see if you go to the studies that the risk or the frequency of wound infections is not statistically different between the minimally invasive surgeries and the open surgeries in spinal metastases. But you will see in all series that the numbers actually are lower, in fact. So finally, what are decisional factors when you're confronted with a patient with a spinal metastasis, with instability or spinal cord compression? How to decide? Then there are more factors to take into consideration than only the neurology and the stability, but they're the first ones for the surgeon. So if a patient has myelopathy, also the duration is important. If a patient is completely paraplegic for 2 weeks, then probably your surgery will not save the neurology of that patient. The patient will not improve again anymore. So that's important. We found in our series that surgery was more effective for radicular pain than radiotherapy. And then obviously there's the thing about imminent spinal cord compression. If you have, for instance, a renal cell carcinoma that is just touching the thecal sac and the spinal cord without actually causing clinical neurological symptoms, knowing that it is a vascular tumor and you would not like to be operating in the middle of the night, in those situations, for instance, it's usually good to be a bit preventative and to do an embolization and do the surgery in a semi-elective way. So imminent spinal cord compression can be important. Stability, I explained, the sin score is important there. And then there's the patient factors. The comorbidities, obviously, is this patient still operable? The patient's wishes, of course, and the expected quality of life, not just the duration, but also quality of life. And the oncological factors you should discuss with your colleagues. Expected survival, very difficult one, and you need each other's help to estimate it. The radio and or chemosensitivity of the tumor, and the time to progression on the last line of treatment is an important factor, I believe. So we would consider surgery if a patient has a sufficiently long expected survival and a sufficient expected quality of life, and has spinal instability or spinal cord compression and or significant radicular symptoms. And this is taken from, and I will conclude with that, taken from the algorithm we use, the protocol we use in our center. So in spinal metastases, calculate the SIN score, estimate the survival, and then speak with the colleagues, the oncologist, the radiotherapy, radiations oncologist, and then consider surgery, as I just explained, in those cases of instability, spinal cord compression, etc., with a patient that is well enough and with a long enough expected survival. So you will do a decompression. You will or will not do a decompression, will or will not do stabilization. And you may consider pre-intervention embolization, followed by radiotherapy, if that is still possible. Now, you should be aware that this is not always the case. Not all tumors are metastases. There are primary bone tumors, and that's a totally different setting. There you have to discuss in the tumor board, including several people, on the best strategy for the patient, and that may include neoadjuvant chemotherapy before the surgery, and the surgery in most instances, and definitely in malignant tumors, will have to be a wide en bloc surgery, because otherwise you severely compromise the chances of the patient. And so that's different surgery, and dedicated surgeons are in for that. And then B, here are the hematopoietic tumors and the histiocytic tumors, and that's not usually surgical disease, so that's then still a different situation. So you would be involved as a surgeon to treat instability or to treat a real emergency or significant neurological deficits, but the treatment itself will usually be non-surgical. Here you see some examples of malignant bone tumors and the schemes that are usually adopted in Ewing sarcomas and osteosarcomas. Those patients will be treated first with chemotherapy. And there is a tendency now also in chordomas, or at least there are some studies that consider neoadjuvant proton radiation therapy before surgery is considered. So that's something that needs to be discussed in an expert team. Now, obviously, you don't know on beforehand whether a tumor is a metastasis or a primary tumor or a hematological tumor. And so just shortly, if a patient has no neurological deficit and you know the primary tumor, it's good to repeat the staging and do a full spine MRI scan, because that will determine the survival and other factors that will be involved together with your colleagues in the decision making. If there's no known primary tumor, again, you will do that full staging in search of a primary tumor. And if you're still in doubt of it, or if it's suspicious for not a metastasis, but a primary bone tumor, for instance, or something else, consider a safe, or it's best to do a safe biopsy without soiling of the tumor, for instance, a CT-guided trocar biopsy. So stage the patient if it's suspicious, biopsy, and then talk with the colleagues that are involved. Now, if a patient has a neurological deficit, well, actually, the scheme is exactly the same, only you will do it in an emergency setting. You will do the staging, the full spine MRI, try to find out what's going on. And if it's suspicious, well, the difference then will be you're talking about a deficit, so it's quite important, something that may harm the patient if you don't treat it well. But you're also talking potentially about primary bone tumors, and it's not wise to just jump into it, because that may severely compromise the survival of the patient. So here, after having done the staging, you should talk with your colleagues in an emergency setting. Take your telephone and call the radiation oncologist, an expert radiologist, the oncologist, and discuss together what should be done. So in these situations, stage, talk, and then if you all consider a biopsy is wise to do first, that should be done. And there are several reports of patients with, for instance, a Ewing sarcoma with spinal cord compression and with deficits, that after the chemotherapy, the emergency chemotherapy, improved neurologically, and then a safe surgery could happen after that. So that's quite important. So to conclude, in metastasis, assess the stability, assess the neurology, spinal cord compression or imminent spinal cord compression, assess survival, very difficult but very important topic. Discuss with oncologists and radiation oncologists and with the patient. Decide on the indication and technique based on the above points. And your surgery in most cases will be as minimally invasive as possible, and it will be a stabilization and or debulking rather than radical excision in the context of a metastasis, and then followed by radiotherapy. Thank you.
Thank you, Bart, for this comprehensive overview on the surgical options in spinal metastasis treatment. So to our audience, when you have a question, please type it in the Q&A box, and we will discuss those questions later on. So I'd like to start with a question for Stephanie. Stephanie, you showed us nicely the different options you have in radiation oncology, the short course fractionated, long course fractionated, and now there's the additional option of the radiotherapy or radiosurgery. So when we look at the control rates, at the local control rates, you show the difference between short course, long course. How does radiosurgery fit in there, or stereotactic radiotherapy? How is the local control rate with this once given high dose of radiation therapy?
It would be in the, it's a good question, because now we have to decide which patient do we treat with what. And with the SBR treatments, we are more in the area of the higher, longer control of the long course, conventional radiotherapy, or even higher. So if you have the possibility and you have a small lesion and you can treat it with SBRT, the patient will benefit in terms of local control because it is more dose that you can give. But then, of course, you have the limitations, large lesion, many vertebrae affected, long area of spinal cord affected, then you might be on the safer side using a fractionated treatment. But local control is higher, as it is a higher dose you give with SBRT.
And then there's the aspect of single dose SBRT versus SBRT or hypofractionated radiation. I don't know how you would term it in 3 doses. Is this very individualized, tailored radiation concepts, or are there real differences in these different fractionation schemes? How do you use those different techniques and radiation schemes?
Yeah, it's a difference if you look at volumes. So the single fraction you would rather treat with smaller volumes, and with the fractionated 3 fractions or 5 fractions, it's a little more forgiving, as you have this fractionation effect, a repair effect on normal tissue. So from my point of view, I prefer the fractionated, so the 3 or 5 fractions, because I think the risk-benefit profile is best. Yeah, if you go for radiosurgery, of course, you have just one single treatment, but you do have slightly higher side effects. But I know there are centers who are really focusing just on radiosurgery, and they have these very individual approaches. But I think for the general broad radiation oncology, the fractionated SBRT is more forgiving and has the best risk-benefit profile.
Okay, you mentioned the advantages of new implant materials. And had some cases, showed some cases where you used it or where it has been used. There's been the question now about stability after radiation therapy, because one of our listeners asked whether there's a stability after radiation therapy is as good as with titanium implants. What your experience is?
Are you focusing on, is the stability the same depending on the implant you use? Or is your question focusing on, do we need the implants to secure stability because we have a risk of fracture after SBRT?
No, the question is whether you have whether the screws are still have the same rate of stability, or whether there's a higher rate of screw loosening when using titanium or those carbon fiber reinforced PEEK implants in comparison to titanium implants. Well, what you
from my point of view, we have not noticed the difference, and we have seen both implants in a lot of cases. So I would say from that point of view, there is not a difference. But I know that you surgeons, of course, use these screws for different other indications so you might have more experience. But from a radiation oncology point of view, there is no there's only a benefit of using carbon in terms of visibility, but we haven't noticed a reduction in instability or anything, or screw loosening or something like that.
This is my experience as well. I'm using those implants in several years, and I don't see a difference to the titanium implants. There's the initial perception that they have less torque, and they give the impression of being somehow weaker, but in the clinical experience, they are not, and they have the same stability as our standard titanium alloy implants. Okay, Bart, has this SBRT changed your approach to meds in any way? Do you see more surgeries now take just decompressing the spinal cord, those separation style surgeries? Is this request increasing in your work together with the radiation oncologist, or does it not really change the way you're treating meds at the moment?
I must say it hasn't really changed things. We're adopting SBRT, but rather in a customized way, actually, the way that Stephanie explained. So it's one of the tools they use, and obviously we decide together, but it hasn't really changed the surgical decisions. I think it's much what has changed. If you compare with 10 years or 15 years ago, is that we apply with the navigation tools, etc., etc. We have the minimally invasive, the percutaneous strategies much more now, which makes sense in reducing soft tissue injury. But the advent of SBRT in our center did not really change our strategies. No.
Yeah. Okay. You just mentioned in your answer minimal invasive. Again, there's been one question, which would be a minimal invasive case for you? Where would you see the limitations of minimal invasive, and say the typical case where you need instrumentation 2 levels above, 2 levels below, and the local decompression? Would you do it minimal invasive, and how?
Well, nowadays I would rather put in my screws minimally invasively, and then make the incision to do the tumor debulking based on where I think that I will reach most the best effect, so it will not any longer, or not necessarily be a long midline incision anymore. So the incision will be shorter, or will be a bit more to the side, in combination with the percutaneous screws. So that would be the way I do it.
Okay, so you showed the literature data on what your own data on recurrences in those patients treated for spinal metastases. That there's one question: were these recurrences local recurrences, or are these recurrences at different points in the spine, or local, where we had the maximum of therapy before with the surgery and radiation therapy?
Yeah, that is a very good question. And the quality of the output depends on the quality of the database. And the GSTSG database is already a very detailed one, but we could not discriminate that. So we could only, based on the post-operative patient forms that, so like the Frankel score was by the researchers each time asked at the patient 3 months, 6 months, etc., but did not allow to discriminate whether that was due to another tumor on a different level than on the same tumor. Now, we do know that if we look at repeat surgeries, for instance, I mentioned a rate of 3% for the index tumor, for the index surgery. There was about a little bit less than 1% rate of new surgeries in patients for a different level. So patients, I have the impression, based on that database and the data I looked at, that spinal cord compression from a different level is less frequent than a recurrent spinal cord compression at the index level. Now, this is a database that has been closed now, and things are changing so rapidly that I don't know if, like, in 5 years or 10 years, my reply would still be the same, actually.
Yeah. There's a question regarding scores. You mentioned it already about Tomita and Tokashi score and the Sorg normogram. The question is, are Tomita and Tokashi scales still valid in the times of modern area of immunotherapy? It says, but modern area of targeted therapies, we have to say. And how do you, at the moment, try to identify the patients which will have a long survival time? And my question would be, is fusion an issue in some of those metastasis patients? Does it play a role? Do we need to identify those patients which will have a long survival time and need to fuse those patients more accurately than we do in the more palliative setting?
Yeah, I will start with the latter question. I always try to get a fusion because you usually don't know beforehand if a patient will be doing well and how long a patient will survive. And sometimes you're surprised. And then, I mean, while you're in there, you do as we usually do in degenerative surgery, etc. We have the tools and the means we know how to aim for fusion, and I do that in the metastasis patients just as well. Even when they receive radiation therapy afterwards, I know the chances of fusion are less, but not zero. Definitely not zero. So now for estimation of survival and the older scores, that's very difficult. I think everybody that keeps his figures and that does a little bit of research on that has about 20% of patients that die within 3 months after the surgery, meaning that probably that was not the best decision. But it's so awfully hard to make that estimation. The other thing happens as well. So patients where you do debulking, and then they come back with so breast cancer tumors, for instance, that breast cancer patients that come back after 2 years, 3 years or later and have a recurrent problem, and then probably your initial decision was also not the best. The only thing you can do, I mean, the scores are useful, and it's Tomita and Tokuhashi, etc. It's better than nothing. But you have to be aware that they were developed in their development cohorts, and their validation in other cohorts was not that great, and it was a long time ago. So things have changed tremendously, and any database that's been created now will not, in that regard, not be valid anymore in 10 years, because things are changing so fast. For instance, Tomita's discrimination of aggressiveness of the tumor, if you present that to an oncologist, they will laugh at that because it's not relevant anymore. There are very aggressive thyroids and less aggressive thyroids, etc., etc. So the only thing you can do is like have some ID, use the best tools available, and I would say the SORC is one of the better tools now, and discuss on a serious level with the oncologist and the radiation oncologist, and try to have some knowledge yourself as well, because a common story amongst surgeons is that the oncologists are way too optimistic, and that's to a certain extent probably true. So you should have some knowledge yourself as well.
Okay, good. Steffi, one more question for you, which came up in the Q&A. What's the ideal timing between surgery and radiation therapy concerning wound healing and any wound healing problems?
Well, I think a good measure is when the stitches are out. Usually the wound is closed and there is no infection, and that's for me a good time to get started. Usually that's around, I don't know, something around 10 days. So something between 10 days and 2 weeks is an ideal time to start treatment.
So you wouldn't wait longer, 10 days is okay.
Yeah, I mean, you can always wait a little longer if the patient, wants to go home for a couple of days, or, wants to just recover. I think that's fair enough. But if you have the impression you have a quickly growing tumor and you want to be, your concern is that wound healing is complete, I always think when the stitches are out, the wound and everything, the wound is clean, you can go and start with radiotherapy, and that's usually around 10 days to 2 weeks.
Okay, different topic now, SBRT and the fracture risk. You mentioned in your talk that the fracture risk is about up to 30% in some series. So this could be a significant problem. Would you like your patients for SBRT pre-treated with a stabilization before they go to SBRT for a selected group of patients, or how do you deal with this problem for the time being?
I think that question has not been solved. You can look at it from different points of view. I mean, one question is, now, do we have to do surgery just to do a new technique of radiation? Meaning we have to stabilize to do SBRT safely. I don't think that's the right way to do it. On the other hand, we have had arguments saying, well, if the patient is stabilized anyway, why not do SBRT? And if we have a fracture, who cares, because it's stabilized anyway. But still, we all know patients go to follow-ups somewhere out there. And then the treating oncologist is confronted with a fractionated vertebra although we might say it's safe, it looks awful on the image. Yeah, so I think it's just something you have to keep in mind, and I think it's not solved. But personally, I think you don't have to stabilize prior to SBRT. You just have to inform the patient that fracture risk is there, and then if it happens, you might have to treat post-operatively, post-radiotherapy. But I wouldn't do a prophylactic stabilization if you don't need it for any other reasons.
Yeah, okay. But would you be worried about fracture and then secondarily trying to correct this fracture, or?
If the patient is stabilized, no. If the patient has implants, no. Yeah. If not, and you do have a fracture, then you have to really discuss what you do, because you might have a compression just by the fracture.
Yeah, my personal experience with that is not, I haven't seen that often actually, the fractures post SBRT. The other thing is that, and that's probably true for several regions in the world, we don't have access to the carbon screws. They're much more expensive, and Belgium has a flat reimbursement rate on pedicle screws, and so no provider wants to bring that on the market in Belgium, because it would, well, from a market perspective, be a loss to those companies, so they simply don't do it. So for the moment still, I do not have access to it, and so I would not. So we base ourselves on the SIN scores and on common sense. I would not, in a preemptive way, do stabilization before the radiotherapy, because my instrumentation then will reduce the accuracy of the radiotherapy.
I think that is with the carbon, that's a problem also within Germany. Not all hospitals allow it, because of course they are more expensive. And you just have to make the point internally that the patients benefit. And I think they do benefit, probably more primary tumors than metastases, because in the primary tumors, you really have to escalate the dose, and maybe 1 or 2 doses, admit 1 or 2 day grade difference may make a difference in terms of curative or not. That maybe not that much the case in metastases. In metastases, I think the argument is that you have a better visibility after treatment, and you can detect recurrences earlier. I think that is also a benefit. And yeah, maybe time will tell, and over time, maybe they will also get a little cheaper once they're spread more widely, and then they may be available more widely also.
Okay, thank you very much for these nice presentations. We are already over our planned time, and I think there would be several further aspects we could discuss, but I would like to stop this now. Thanks, very good presentation. Thank you for this nice discussion afterwards. We had quite good audience of 160 participants, which is nice. Thank you for everybody who participated and to watch this and entered the questions. Sorry for those questions which have not been answered. We will try to answer this in the chat box later on if possible. Enjoy the rest of your evening, and goodbye.
Bye, Florian. Thank